let's keep going with the next session. Unfortunately, we don't have 3 panelists, only 1. You're alone there. Maybe you prefer to sit here.
No, I'm fine here.
This is a special session because it's, I don't know, maybe the youngest do not know that this device is not really new. We are very close to the 20 years of the first publication by Bruno Scheller, 2004. Next year is 20 years. Time goes by so fast. It's 20 years we are still learning about these devices, and it's important that we are still requiring more and more research. And in this session, my co-chair is Dr. Juan Sanchez, and the panel is Rafael Ruiz Almeron, and it's about expert recommendations and consensus documents. And we are going to start with questions, and I think the first should be in the screen for you to answer, and maybe with Rafael we can discuss the outcome of the polling. The first is regarding DCBs. Do you believe that current ESC clinical guidelines on revascularization are adequate, too restrictive, required to be updated? Which is a good answer. No? Second is too restrictive. No, the winner is no winner. There is a tie between too restrictive and required to be updated, which is interesting. What do you think, Rafa?
I think that probably should require an update, because each time we have new data, and all of us, I think that we think that this technology is really very attractive to other niche, that even the interesting is stenosis, but also for another application could be used.
Yeah. Always guidelines are always behind the evidences, because there is a trial that is released immediately after the last version of the guidelines, and they say the guidelines are outdated because
I think we need more data to improve their presence.
Next question. Please, the next. Let's see. Regarding expert consensus documents on DCBs, they are. In order to congratulate, I think there are authors of these papers here. We are not going to be very critical with this. Adequate balance and detail. Too biased? No, I don't know. I prefer following the guidelines. I don't know. I think the clear winner is adequate balance and detail, which is a good qualification and appreciation for the authors that are hearing for the document. No? What? You think?
I think I will say they are well balanced and very well written. The others are here, of course.
Exactly. This is very clear. Then let's go to the next question, if there is one more. One question, practical and technical. This is for lesion predilatation before DCB. I don't know, maybe we use of everything, no, Rafael?
Yes, it depends on the lesion, but usually I use non-compliant balloons.
Non-compliant?
Yes, non-compliant balloons, yes. Most of the time, because I want to be very sure to have an one-to-one vessel balloon diameter relationship. So this is usually my first choice.
No one?
I usually use non-compliant balloons.
Non-compliant, but maybe people also conventional, scoring, of course. What is needed to have a good angiographic result? No? Then you do not apply the DCB after you get a good preparation. Okay, this is clear. Next question, please. No more questions. One, please, okay. You can introduce.
First of all, it's my pleasure to be here co-sharing this session, and thank you very much, Fernando, for inviting me. So now we have 3 excellent talks by excellent speakers. The first talk is Evolving Clinical Experience with DCB, Where Are We Now? By Bruno Scheller.
Yeah, thank you very much. Thank you, Fernando, again for the invitation.
Mechanical dilatation with restenosis inhibition via drug-coated balloons.
Then let's start again. I wanted to show on you the pictures of our first prototypes, but without this sound. This is a very nice paper from Adnan years ago about the reason was 40 years of angioplasty, which was celebrated in 2017. And here you can see very well the development of the area, and we're very happy to see that our first clinical paper, which Patrick knows very well from this time, was mentioned in this timeline. And as said before, we have now more than 20 years of preclinical experience with DCB and 20 years plus clinical experience. And the first consensus document was also created more than 10 years before. This was the first Berlin meeting we had in 2011, and with the support of Patrick we could create this Euro-intervention supplement. And already at this time the basic concept of starting with lesion preparation and then deciding what the outcome is of your lesion preparation, and depending on that you can decide if you use only DCB for local drug delivery or use a stent, was already created in 2011. So the guidelines has been already discussed. We have meanwhile for the treatment of instant restenosis a 1A recommendation for the use of another stent or the use of a DCB for the treatment. But the guidelines also clearly state that there is no convincing data that support the use of DCB in de novo lesions. So now we are in the year 2023 and still ISR is the only accepted indication for the treatment with drug-coated balloons in the coronary arteries. In my opinion, ISR is the worst indication we have for drug-coated balloons. The results are overall similar to the use of another stent. The stent approach seems to be more effective. The DCB approach has the hope to be more safe over the long term, but this has to be proven. But at the end of the day, the most interesting indications are the de novo indications. And there's clear unmet clinical need. 2 papers on the device-related event rates from drug-eluting stents over a longer period of time, and it is clear that if we implant drug-eluting stents and especially long and multiple stents in younger patients, they have a high risk for events related to these implants they get. I will not go in the different indications. We will discuss all this later on, including the evidence if it's available. I want to point only on a few mechanistic things when using DCB for de novo disease. Number one is what had also already been shown by Bernardo, is the history of dissections, that many dissections are benign and you can leave it without any risk of vessel closure. And for example, in the basket small 2 trial here, in the angiographic sub-study, there was no single case of vessel occlusion in the DCB group, but a relevant number of occluded stents we have seen, which were clinically silent because there were small vessels we treated, but nevertheless it seems to be safe to leave a vessel without stent implantation. This is also reflected in this meta-analysis we conducted in the randomized trials. In the first year there was a lower risk for myocardial infarction when treating the arteries with DCB only. The next very important feature, at least for paclitaxel balloons, is what has also already been discussed, is this effect of late lumen enlargement. This means we have an improvement in the majority of lesions treated over time of the lumen, and this is the basis that we can accept non-stent-like result in the beginning, because we have some improvement over time. The main mechanism is an increase in total vessel area, which may be due to the fact that we have this higher concentration of paclitaxel in the adventitia, which has been shown by Reno in her talk. Another interesting feature, maybe if we discuss bifurcation treatment, is the fact that if you treat only the main vessel with DCB only, we see an improvement in the ostium of the side branches over time. I think that's very interesting. And another second interesting finding when looking at this lumen enlargement is the fact that there is an influence on the plaque volume if we treat the artery with drug-coated balloons. So there's also experimental data with paclitaxel showing that there is a suppression of inflammation and maybe a reduction of in the progression of arteriosclerosis. And this has also been shown in this paper, which has been shown by Bernardo before, from Japan, that they see this lumen enlargement as a result of total vessel growth and a reduction of plaque area. And this gives us this new concept that if we do DCB only treatment, we see an improve in lumen over time due to the fact that the whole vessel gets bigger or that the plaque area is reduced. And the last very important feature of DCB only treatment is vasomotion. We have several papers now showing this. For example, in this paper, you can see that vasomotion is restored in the area treated by DCB compared to stent, but also in the distal segment treated from the DCB. DCB is not a replacement for stents, but an additional tool to reduce the total amount of stents we implant. And this work from Dr. Shin's group from Korea has already been shown. When treating multi-vessel disease, you cannot treat those patients without stenting, but you can reduce the stent dramatically, and this may result, this is a retrospective data, but this may result in better outcome. So where are we now with clinical evidence for DCB? We have still only the guideline recommendation for the instant restenosis. De novo, in my opinion, is much more attractive, but not recommended. And we should discuss what evidence is required for the guidelines to support the use of DCB also in de novo lesions. Thank you.
Let's go to next presentation. Third International Consensus on DCB, Take-Home Messages by Raban and Jäger.
Thank you very much. It's again me. Hello, everybody. You just heard that in 2018, the ESC guidelines just mentioned instant restenosis as an indication for DCB use. And based on this, and based on the many trials and clinical evidence and randomized data we had, I remember we sit together in San Diego at that time, and a group of people, and we said we will do a consensus paper of our own to, in a way, counterbalance this missing guideline recommendations. As we already heard, there were now the first of this consensus group recommendations was done in 2010. At that time, it was a German consensus group, and then it grew out of Germany towards the south, to Switzerland, and then at the end, we went international, and 2020, we had this third report of the International DCB Consensus Group that was published in JACC Interventions, and in the upcoming minutes, I want to share with you the content of it and the main messages. So the content is, these are the chapters in this paper. We were talking about local drug delivery, the technical considerations, the angiographic and the clinical indications, the future perspectives, and then we shortly discussed the mortality risk with paclitaxel that was upcoming at that time, and then we concluded with some messages. So the basis of it all, we saw that, is the failure of metallic implants in coronary arteries that occur at about 2 to 3% of cases every year. This is a fact. We have seen that in some publications, and here the largest of these publications is this publication from more than 25,000 patients from 19 prospective trials. And they very nicely showed that irrespective of the metallic implant, drug-eluting stent generation 1, drug-eluting stent generation 2, bare metal stent, whatever, there is an event rate of 2% per year, and this is, in my opinion, too much. It could be that the reason why PCI is not as good as CABG can be this, and I think if we want to avoid patients being operated on, then we should have another option. So we collected the data. There is some robust data for many indications. Incident restenosis, we have seen that already. There is the indication of high bleeding risk. There is the indication of small vessel disease. There are several randomized trials here in this field, and also for bifurcations. And these are the main possible indications for DCB. And we said in this consensus paper that the DCBs are a novel therapeutic strategy for special situations in coronary artery disease. And we talked about all these possible indications and showed all these trials. One very important message from the consensus paper is that there is no class effect in drug-coated balloons. We already heard about this. The reason is that there are different balloon catheters with different coating mechanisms. There are different excipients used. There are different active drugs used. And based on this is the message that every device needs to show its own efficacy and safety. There is no class effect that you can just think of. Another chapter is the mechanism of action. I don't want to go too deep in this, but for example, here in this cartoon, there's an incident restenosis, a stent failure. The balloon is getting inflated, and as you see here, there's this lipophilic or not that lipophilic drug with a coating matrix that goes into the vessel wall, and it's getting in very fast, and this exerts the action afterwards and makes the efficacy of this device possible. And then there is this famous paper here, the central illustration of this consensus paper, and in the centrum of this central illustration is the lesion preparation, as you heard it many times today. But what are the other main messages here? One main message is that DCB and DS are a complementary tool. It's not either or. It's a mixture. It's a blend. It's a hybrid procedure. You can use both, and you can mix them as much as you want to, and these are not exclusive options. Another message is, as I told you, there is this optimal lesion preparation as the central element. Then we defined what is an acceptable angiographic result. We thought at that time that type A and B dissection, eventually C dissections could be acceptable kinds of dissections. We said this is the no flow limiting dissection that is possible. This is acceptable, and I think to get around or to avoid this type A, B, C, D, E dissection types, I think the flow limitation is a good expression. Then we said quite deliberatively that a result stenosis of 30% is acceptable. We heard some people are 50% or 40%, nobody knows exactly, but 30%, this is a more eyeballing thing, should be acceptable. And the functional measurement, an FFR of more than 0.8 according or parallel to the DES data is acceptable. And then, as we heard, the possible means of achieving the optimal lesion preparation are listed. There's this definition of a balloon to vessel ratio of 1 and the additional options such as rotablation and such as functional measurements and intravascular imaging, as we heard. The future perspective, mainly talking about sirolimus. Just one example here, the sequent please against the sirolimus-coated balloon from B. Brown that has been tested in this trial here. This is very important that the new drugs are getting tested against established devices. And then at the end, the toxicity of paclitaxel. There has been rumors that this medicament is killing people. And here Bruno Scheller could show that in all these trials in more than 4,500 patients, this is not toxic to patients. You don't kill patients with the paclitaxel-coated balloons. This is something that more gives a favorable result regarding all-cause death and cardiac death, and it's not harming the patients. And at the end, the take-home messages of this publication is that there is a change of treatment concept in coronary artery disease. There are some limitations in certain clinical and anatomic conditions, and DCBs are a new or a novel therapeutic strategy for coronary artery disease. And besides the incident restenosis, there has been, or there is new data that show new possible indications for native or de novo coronary artery disease. And one really important thing is that future research will be necessary. Every device and every indication has to be proven by randomized controlled trials. Thank you very much.
Thank you very much for the excellent talk. The last talk, why do we need ARC definition for DCB? By Professor Patrick Service.
Yeah, I think that all the experts are in the room, and indeed at PCR we were something like 29 people in that small room. There was some lack of oxygen at the end of the meeting. So, drug-coated balloon, academic research consortium ARC. The first point is that we try to establish dedicated study design, parameter of assessment and endpoint, acute technical procedural success, and long-term clinical outcome. And it's clear that we are looking at the method of angiographic assessment, the role of intravascular imaging, non-invasive coronary imaging, including CT scan, and image-based or invasive method for functional lesion evaluation. The interest is in the antiplatelet therapy type, duration, intensity. And then you have the concept of blended therapy combining various devices instead of comparing device itself. So we are looking at strategy of treatment. The objective, classification of DCB technology, molecule and type of elution and coating, criteria of optimal pre-treatment prior to the application of DCB, type of clinical studies, first in man, study of regulatory approval, device comparing study, procedural, mechanistic, anatomical and functional, clinical and cost effectiveness endpoint, patient device, vessel and strategy-oriented endpoint, patient site and central adjudication reported endpoint, and follow-up method, angiography, intracoronary imaging, non-invasive imaging, and finally, analytical plan relate to intention to treat per protocol and as treated analysis with the option of even sham treatment. You have heard there is different type of molecule and also different type of coating. Hydrophilic matrix, you can read the product on the right-hand side, phospholipid-based, micrometer nanoparticles like the nanolute and mucoviscous approach that exists. Now, I must say that the field is overcrowded. At some point, we had 40 drug-eluting stands. I'm sure that some of them will disappear. And I think it's like in the Bible, Matthew 22:14, at the wedding many were called, but few were chosen. I think that will be the case for the drug-coating balloon. Lesion setting, very clear in standard stenosis, de novo, and bifurcation. In the de novo, you can have large up to the left main. That's my fellow in Korea. Small, what is small? A vessel. Which technology to investigate that? One, to treat. Do we need more than 10% of myocardium? Diffuse, what is diffuse disease? Which technology? Again, angio, IVUS, or CT physiology. Calcified lesion, we have to debulk. Iris lesion, flow limiting, non-flow limiting. There is even at the VPM meeting a session on drug-coating balloon for vulnerable plaque. You have bifurcation in the main vessel, in side branch of both. And then you have basically the three big clinical setting: diabetes mellitus, iris bleeding, and myocardial infarction. I like that slide, but I think we are moving. That's already almost 3 years ago. And of course, the question is preparation. That's really obvious that we have to do that, and I will show you a slide about that. And then there is the 3-point, no flow limiting dissection, residual stenosis less than 30%, NFFR more than 0.8. A lot of discussion in the group. Let's start by the preparation. I have in my lab 7 Chinese fellows from Xi'an and work with these people for a long time. You see the pictures of Professor Lin Tao, which has spent 6 years in Philadelphia. And in the randomized trial that we have finished 1 year ago, we are in the 11th month of follow-up, we randomized 2,270 patients and 2,517 lesions, paclitaxel versus sirolimus drug-eluting stent. And the good news is that the blended therapy is already there, because if you look at the DCB group and the DES group, there are almost similar number of scoring balloon, non-compliant balloon, and cutting balloon. That's really good news, and I think these two groups will be highly comparable. It will be presented over one year because the primary endpoint is at 2 years. Now, the second point is, can you trust QCA? This is a randomized in small vessel, and you could see it was indeed small vessel by QCA, 2.07 for the drug-coating balloon A and B. The OCT was classically 0.4, 0.3 biggest, 238. So for the QCA, you have to take a ratio of 1.2, 123%. For the OCT, you can take a ratio of 1. So I think that's an element of response. Now, intimal fractures and subintimal dehiscence, that's the name I like. That's the DCB of the balloon angioplasty mechanism. And it is appropriately detected by OCT. In the most recent trial, by OCT assessment, 95% showed dissection versus 15% by angiographic assessment using the classification A, B, C, D, F. The method that you see here, measuring frame by frame, the volume, the area of the dissection, is very robust. In that randomized trial, we had as a median volume of dissection 2.12. You see the cumulative curve. And here you can appreciate the substantially investigate the site heterogeneity in terms of extent of dissection. This is the method, frame by frame. So in that trial, there is 10,000 frames analyzed. You have seen the cumulative curve for the dissection. But I think what is very important is this relationship. We have there two drug-coating balloons, the DCB A and the DCB A and B. And as you could see, if you start by the DCB B, the late loss on the vertical axis is independent of the volume of dissection. That's quite remarkable. There is even a small negative relationship for the drug-coating balloon. For the drug-coating balloon A, there is a relationship between the volume of dissection and the late loss. So that's something we have to take into account in the future. It's obvious that the transfer and the retention of the drug in the vessel wall play a key role in the success of the DCB therapy. Before the cage-free randomized trial, which is finished, we did with our Chinese friend a registry, which will be published very soon. 1,665 vessels, and as you could see, we have analyzed by 3 QCA systems, MEDIS in Europe, Pulse, and RainMed in China. And we work together, and I told you 7 of these fellows are in Galway with us. What we have found is that the median diameter stenosis is 30%. You can see here the residual and the median. 80% of vessel below to 40% diameter stenosis, and more than 90% of the vessel have a diameter stenosis below 50%. The big discussion in the ARC consortium, when a direct comparison between DES and DCB is intended, DCB ARC would like to recommend to apply a specific threshold to each device. Big discussion. Less than 50% for DCB, less than 20% for DES, visual. But I think that what should be done, and some of us believe that stratification, post-preparation, and prior randomization should be done between less than 30 and 30 to 50. Why do we say that? Because if you look at the registry and look at the diameter stenosis and using what we call standardized log rank statistic here, you could see that the maximally selected rank statistic is for 25% diameter stenosis. So if you look at the hazard ratio for Poche versus that parameter of 25%, it goes down below 25%. It is almost a plateau between 25 and 40, and it's increased sharply above 40. This is the same, but this time is the Poche probability versus diameter stenosis. And you could see the same phenomenon between 25 and 40, there is a plateau, but after that it raised massively. If you divide the follow-up at 3 years now, you could see in green the Poche, patient-oriented composite point, above 40, in red 25 to 40, and then the less than 25 in blue. That's the reference. As a matter of fact, only the more than 40% is significantly different. This is a very important slide because it is in small vessel, I have to say that. We split the population in less than 30% and more than 30% post-procedure. there is 2 drug-coating balloons, A and B, and you could see here the case which has an acute gain. By the way, it's interesting to see that A has an acute gain which is bigger than B, which is 0.59. There are also suboptimal cases where the acute gain is equal, 45 and 44. They are here. Now, what happens with the drug-coating balloon A is that a lot of loss is taking place, which is not taking place with the drug-coating balloon B. So the late loss, 53 for A, 0.9 for B. But look at the suboptimal. There is even some late gain with B and a very limited loss for the A. So that at the end of the day, the B has a net gain of 51 in this small vessel versus 20, while in the suboptimal, they are quite not similar, but 31-49. So the difference between the optimal treatment and the suboptimal treatment is not exactly what I was expecting, but we will analyze that in more detail. Another approach is the quantitative flow ratio. That's a little bit what Antonio is doing. This is a post-DCB, 1.8 millimeter, diameter stenosis 23%, QFR 91. At follow-up, 192, diameter stenosis 17, and QFR 93. Again, I go back to the cage-free registry because, after all, it's a 1,600 vessel, and that has been done very carefully by 2 academic institutions in different continents. And you could see here the hazard ratio for Poche, which increased below 0.89. That's basically the best we have found using, again, this standardized log rank statistic. That's the best, 0.89. And you could see also that below 0.99, the probability of Poche increased in red, and above 89, the probability of event decrease. So we like that value. Let's say a word about the type of study. You have, of course, first in men. You have the study for regulatory approval, including IDE, FDA, and PMDA. You have device comparing study molecule coating, strategies, leave nothing behind, crossover strategy, or blended strategy. You have medication, monotherapy, dual therapy, duration, and maybe even sham. In terms of composite endpoint, you have, of course, classically Poche, Doce, Voce, Loce. Loce is the last one, lesion-oriented composite endpoint. You have what the FDA like is the patient-reported outcome, because that's what is important at the end of the day. SCQ, Seattle Angina Questionnaire, Eurocall 5-domain, SF3612. You have procedural endpoint, acute device success of acute lesion success. Surrogate endpoint, the invasive one, angiography, intracoronary imaging, physiology, pressure Y of angio-derived of IMR. We just discussed that during the discussion, that the IMR may be increased more with paclitaxel than with sirolimus, shear stress eventually, and then non-invasive and multi-slide. Here you see the parameter that we like. I have already presented: acute gain, acute recoil, loss, net gain, degree of stenosis. Geographical miss has to be considered. It has been too much ignored in that phase. To go back to the surrogate endpoint from angiography, I'm puzzled by the fact that in this classical study of instant restenosis, you see a lot of discordance, of inconsistency between late loss, MLD, diameter stenosis. Sometimes it favors the DCB, sometimes it favors the death, sometimes it's equal. In the de novo, it seems that there is inconsistency between late loss and MLD, late loss and diameter stenosis, but I must say that there is some good consistency between MLD and diameter stenosis. MLD and diameter stenosis gave more attribution to clinical endpoint compared to late loss. This is the technique that we use for analyzing the geographical miss. It's an electronic superimposition of the location of the balloon versus the angiography immediately after retrieval. Geographical miss is there. We should look at more carefully to understand the plan. Adjudication of TLR, I'm not going to describe that, but it is now pretty well codified in ARC2, and you have to follow that scheme. And then my last slide is for the composite endpoint and repeat event interaction. That's something that I spent some time on it a few years ago, a statistical method for composite endpoint. What we all do is time to event first event. That's classically the Kaplan-Meier curve. You use the first event, you don't use all the event, you don't use death as the most important, you use time to event, and you don't give a weight to the event. Everything is equal. Death and thrombus, death and TLR is identical, but the principle is first an event, and we all do that. We work a little bit on the win ratio, where you don't use the first event, you don't use all event, you use death as the most important, you don't use the time to event, and you don't give a weight. It's not my favorite. Cox-based model for recurrent event, you use the first event, you use all the event, you don't use death as the most important, you use time to event, but you don't give a weight. And my favorite is the last one, which has been practiced for many, many years, and Anand Kastrati will remember that in global leaders, there was a p-value of 0.052, so we didn't make it with a classical time to first event. But we published that with the weight composite endpoint, we did a very significant trial. Publication is not very frequently quoted, but is important. Why I like the weight composite endpoint? You use the first event, you use all event, you use death as the most important, you use the time to event, and you give a weight. Think about drug coating balloon. So far, we don't have too many deaths. That's not something we see. What we see is TLR. So that is something which will be very good if we use the weight composite endpoint. So in conclusion, we all agree that so far there is no class effect which exists for this category. And DCB ARC is an expert consensus, so you have to listen very carefully to everybody. Of course, we are also called opinion leaders, so sometimes there is very strong statement with very little fact. So I think we have to go after the fact, and that's what I try to do with many of the group to try that. Because ARC is not a consensus, it's not a consensus how to do it, it's not a review of the literature, it's basically a group who try to provide the cardiology community with solid and consistent rules of engagement for clinical trial in the DCB. That will be the only way to be recognized by the community and by the guideline. The problem of the guideline these days is the following. They don't use any more expert. They believe that the experts are biased. put forward their own research. I did that. I mean, I was in the guideline of the revascularization on bypass surgery. That was just at the time of the syntax. I put the syntax score in the guideline. They are still there. So that's the reason. But the big disadvantage not to use expert is that the guideline go forever. We are still waiting P2Y12 guideline. Thank you.
Thank you very much for the excellent presentation.
So, this has been, Patrick, a really new and insightful, in-depth analysis, and it's very appreciated. We are running out of time, but I only had one question, because the main advantage of this technology is that you don't leave behind any metallic thing. And to start with, you think, okay, then you are not dependent on the APT. Let's study, or let's make a trial evaluating single antiplatelet therapy. We are treating daily more and more elderly people with on our anticoagulation because AFib, high bleeding risks, people with cancer, whatever, but there is no trial so far in 20 years, properly conducted, demonstrating if we can really put the patient only in one single antiplatelet agent after this technology. This would be fantastic, because you are opening the door for a lot of patients that are in high bleeding risks to be treated with just the DCB and one single agent for the following months. Why not? Why there does not have been an interest in these years for conducting trials with single? There are very small experiences published, single registries, very small, nothing. Bernardo, we have discussed many times this, a trial addressing this. I don't know why.
Well, actually, we have designed the trial, and we will run it with EPIC. So I agree with you, the time has come. We have some preliminary data, we have published it, we will present it. Also Thomas has a good experience with it, but we need a randomized trial. So Piccoletto 4 EPIC will probably answer this question. But you know, the problem is, it's dual, I think. First, to find the money for doing good, high quality clinical trials. And second is to find centers that will enroll patients in a limited amount of time, because we don't want to run a study. Piccoletto 4 will have 500 or 600 patients, so it's not a very large study. We want to finish it in 3, 5, 6 months. That would be optimistic, but you know that the real life is associated with a 1 year, 2 year of enrollment phase.
Yeah, two possible answers. Amnon?
So we have been moving from debt long term to debt short term, and it involved the stent implantation. Do you think that the same strategy will involve also DCB, knowing that portion of the patient will have dissections left intentionally there?
Yes, well, we did obviously this in a highly selected population. We have analyzed it, which is a patient with a high bleeding risk. We will see in a broader population in Piccoletto 4, hopefully. But my point, again, I repeat it, I already said, the point for the dissection is to have a good anticoagulant for some time, for a few hours. So you don't need a potent to do antiplatelet therapy. This is my belief. For long term, it's okay, but not for the lesion. So now we have to think at the patient. For example, the ACS patients benefits of a prolonged dual antiplatelet therapy, as we have seen with drug-eluting stent, but that's not related to the lesion that we have treated, but to the benefit of the patient. In a sort of quiescence of the potential other lesions that can come out symptomatically.
I think you have also to consider, because we have looked at the beginning with PCI and with PDCA, when we used the bailout stenting, we had a very strong anticoagulation. We used 150 units per kilogram, which is, for now, it's extravagant. And despite that, we had occlusions.
You want to go first?
Yeah, I mean, I still want to go back to the DCB in large vessels. In my hospital, there are many senior interventionists, they are very opposed. They say DS well implanted, IVUS guided, with optimization, do very well. the long-term failure are related to the DS not optimally implanted. So why don't we work to improve DS implantation instead of find alternatives? I want you to help me to answer this question, this remark.
I think that there are big changes about that time and the present time. You know, there are 15,000 patients, STEMI, non-STEMI HPR, in trial, randomized trial, without aspirin at all. That's point number one. And Takeshi Kimura at ESC will present his first 36,000 patients, STEMI, non-STEMI. 3 times the DSMB has said you can go on with the trial. We just published in Circulation Journal the ASSET Japan, where we didn't use aspirin. The reason why in 2011, before the global leaders, I was trying to convince Stefan Windecker, Marco Valgimigli, and Pascal Frank to abandon aspirin was simply 2 publications. One in Gastroenterologica, where they do gastroscopy 2 times with 7 days of aspirin. 40% of erosion after 7 days and 20% of ulceration. That's randomized data by gastroscopy done by the gut in 2011. Interventional cardiologists did not read that paper. The same years, we have Armstrong who published 6 agonists. Aspirin did not do anything on top of prasugrel, 0, in all the tests with all the agonists. So I was proposing at that time to Stefan Windecker, let's skip the aspirin. Of course, that was a tolle. They said, Patrick, you are crazy now, no aspirin. So I came back 1 month later or 2 months later, and I said, 7 days. And they said the same. Finally, we did 1 month. Now, that's not yet in the guideline. We are 10 years later, it's not yet in the guideline. So I'm pretty sure that with the DCB and the prasugrel, which is a pretty good job, you like the prasugrel, I think it will work. I think it will work. That's the first thing we can try, is to eliminate aspirin, because aspirin is not, it's a very weak platelet agent, but it's the cause of bleeding. The cause. It's create erosion and ulceration. So that's the first thing we have to do.
But if you eliminate aspirin, I agree with prasugrel, but in large number, would it be uneasy not to test clopidogrel resistance? Because we had one single patient in my career with DCB who had thrombosis and was a patient only on clopidogrel. I called the patient back and he was resistant.
Right. You know, in this patient who had OCT after the preparation but before the randomization, we saw, because we were looking frame by frame, we saw small platelet without shadowing behind, so there must be a platelet. We didn't, the investigator apparently didn't see it. We saw it because we have the time to look at, nothing happens with this patient. Nothing, not a single thrombose. There is one late closure silent in that trial. So I think that we have today a P2Y12 very good. We didn't have at that time of balloon angioplasty. How many times I went back at 5 o'clock for thrombose of the balloon angioplasty? That was the classical time, 5, 6 p.m. That was. But I think we can do it without that.
Yeah, I will address HPR in detail in my presentation, but just one comment on the population, because it's very frequent to have HPR patient in cath lab. It's about 40% of the whole population. And the most critical time for bleeding is the first 4 weeks after PCI. So if you implanted a stent, there's not much you can do actually about or if there's an operation, surgical operation. But if you have a routine to have a DCB only in this population, you can even stop the duct during the first few weeks. We have preliminary data on that, so it gives you more options.
Okay. Any other question, Rafael?
Yes, I have a question for Professor Llaga, because in the chapter how to use the DCB, this is one thing that concerns me always, that when I use the DCB technology, that is, the balloon loses the drag. The balloon loses the drag during the navigation with the blood, or when you are fighting, trying to reach your lesion. So you have one dosage of the balloon when you open the box out of the patient, and another dosage when you treat the lesion. And this dosage is quite different among the different patients. So that loses the predictability of the therapy. So, and we have to take into consideration that these balloons, or at least the balloons that I use, they do not deliver quite well. So, don't you have some recommendation how to use the balloon to treat mid or distal lesion? For instance, to use routinely the guide extension or something like that?
This is a very good question, and this is a question I always are asked by some critics, that they don't like the balloon. My personal approach for it is that I really are preparing everything that I'm as fast as possible to put in the device. So guide extensions is a good thing, some wires with high resistance, some extra strength wires. I pre-dilate the lesion, that there's really a soft progress of the device into the vessel. And I'm not touching anything. I prepare the balloon without aspiration. I really look for a no-touch technique and a fast delivery to the target lesion. And I think if you are in the prospect, they say 2 minutes. I'm 99% less than 20 seconds in the lesion, and I think with this small amount of time, you don't have a problem.
Okay, we're going to finish the session. Thank you very much for an exciting talks and interaction with the audience.
A coffee break, no, Fernando?
So this is just a 10 minutes break, so we need to reconvene here at 12:15.